So today we'll discuss the paper titled Efficacy of Stereotactic Radiation Therapy for the Treatment of Confirmed or Presumed Canine Gliomas. Just to go over some background of intracranial gliomas for anyone not familiar with it. Intracranial gliomas are the second most common type of brain tumor in dogs. These tumors have similar features with human gliomas, and they can be classified into different subtypes. However, there is insufficient clinical evidence to determine how the grade and or the subtype of glioma affects the prognosis in dogs. Surgery might not be an option for gliomas depending on their location. Chemotherapy is limited to drugs that can pass through the blood-brain barrier, but there is no clinical evidence of its effectiveness in treating canine gliomas. Radiation therapy is a minimally invasive treatment option that can significantly improve survival times of dogs with gliomas. Palliative medical care alone has a short median survival time of 35 days for dogs with gliomas. However, retrospective studies published recently showed promising results using hypofractionated stereotactic radiation therapy with a median survival time of almost 8 months, even after a single course of 24 to 30 gray stereotactic radiation therapy. The prognosis for macroscopic canine gliomas may be more favorable when treated with stereotactic radiation therapy and chemotherapy or multiple courses of stereotactic radiation therapy. The stereotactic radiotherapy has also been shown to be well tolerated with minimum radiation-induced toxicities to the surrounding tissues. There are emerging reports of longer survival times ranging from 489 to 698 days associated with more conventionally fractionated radiotherapy protocols. However, unfortunately, there remains a population of dogs that do not respond positively and or for long in these reported canine glioma cohorts. This retrospective study aimed to evaluate therapeutic outcomes from a similarly sized cohort of dogs as featured in recent canine glioma stereotactic radiation therapy studies, and also to investigate the safety and efficacy of stereotactic radiotherapy in treating canine glioma. The secondary goal was to evaluate potential prognostic factors in this cohort, including the degree of contrast enhancement on MRI, which has been linked to higher grade tumors and tumor location, which was found to be prognostic for outcome in a previous retrospective study of canine glioma treated with radiation therapy. So to summarize all that, while surgery might not always be an option and chemotherapy has no clinical evidence of its effectiveness, radiation therapy can significantly improve survival times in dogs with gliomas. Stereotactic radiation therapy and conventionally fractionated radiotherapy protocols have shown promising results in recent studies, but there remains a population of dogs that do not respond positively to these treatments. This study aims to evaluate the safety and efficacy of stereotactic radiation therapy for the treatment of canine glioma and identify potential prognostic factors to optimize safety and efficacy of treatment and predict treatment response. To summarize how the study was performed, medical records were reviewed from 2010 to 2020, looking for dogs that had stereotactic radiation performed for a glioma. These dogs either had a presumptive diagnosis based on MRI characteristics or were confirmed with biopsy. Radiologists identified these characteristics as intraaxial T1-weighted isotohypointense and T2-weighted isotohyperintense mass lesions with varying degrees of contrast enhancement, and then classified the tumors based on contrast enhancement or lack thereof. Data collected included patient signalment, clinical signs, tumor location and size, imaging records, histopathology records, medication regimens, radiation dosimetry profiles, toxicity reports, clinical response, time to death, and cause of death. For the neurologic status categorization, dogs with no neurological signs were classified as none. Those with mild symptoms controlled by oral medications, like infrequent seizures, were classified as mild. Those with severe neuropathic symptoms like paresis, ataxia, loss of cranial nerves, or uncontrolled epilepsy were classified as severe. For diagnostic tests for staging, patients underwent full staging for their malignancy that included baseline blood work, thoracic imaging, 3-view radiographs and CT scans, abdominal ultrasound, and CSF analysis if indicated. For cross-sectional imaging, pre-contrast helical CT imaging preceded intravascular injection of the Omnipeg 350 contrast media. MRI studies followed with a 1.5 Tesla MRI. Sequences obtained included T2 weighted images in the transverse plane and T1 weighted images in the transverse plane before and after IV gadolinium administration. The T1 weighted post-contrast MRI was manually co-registered with the planning CT images in the software to mitigate delineated tumor margins from normal brain tissue in dogs. For radiation treatment planning, a 1 millimeter isotropic planned target volume, or PTV, expansion accounted for positioning errors and patient movement during treatment. The prescription goal was to give 100% of the prescription dose to 99% of the gross tumor volume and 95% of the planning target volume. Normal tissue toxicity was evaluated according to the Veterinary Radiation Therapy Oncology Group's toxicity grading scale. For the response criteria, tumor response was evaluated according to response evaluation criteria in solid tumors based on pre-treatment MRI measurements compared to post-treatment MRI. The overall survival time was determined from the onset of radiation therapy to the day of death. The overall survival time was determined from the onset of radiation therapy to the day of death, accounting for cause of death, or if not reported, presumed to be glioma related. For statistical analysis, the Kaplan-Meier survival curves of overall survival time were created using GraphPad software. The correlation of predictors, including the gross tumor volume to brain ratio, gross tumor volume, and total dose to 99% gross tumor volume, were analyzed with univariate Cox proportion hazard regression. Survival outcomes for factors including tumor location, degree of tumor contrast enhancement on MRI, brachycephalic breed, and second malignancy were compared by log rank test. All statistical analyses were performed using the commercial software Prism. For the results, a total of 23 client-owned dogs were included in the study, all of which were treated with stereotactic radiation therapy for confirmed or presumed glioma. Presenting clinical signs of dogs with confirmed or presumed intraaxial glioma treated with SRT included reported seizure activity in 65%, neurological deficits in 39%, and/or behavior changes in 13%. 3 dogs in this cohort had histologically confirmed glioma prior to stereotactic radiation therapy, and the remaining 20 patients were diagnosed with glioma through imaging. Of these, 4 dogs had cerebrospinal fluid evaluation, and 3 out of the 4 dogs had a normal CSF fluid. 8 dogs were also affected with 1 or more malignancies in addition to their glioma. Concurrent medications at the time of treatment included prednisone, levetiracetam, phenobarbital, gabapentin, and dexamethasone. 2 dogs were treated with concurrent lomustine chemotherapy. All dogs underwent imaging with CT within 2 weeks prior to initiating radiation therapy. SRT protocols were described and ranged from 16 to 27 gray. Dogs were treated with prednisone at a dose of 0.5 to 1 mg per kg per day. All 23 dogs had follow-up veterinary evaluations post-stereotactic radiation therapy. In this cohort, the median overall survival time was 349 days, and the median disease-specific survival time was 413 days. Factors including gross tumor volume to brain ratio, tumor volume, dose to the gross tumor volume, tumor location, brachycephalic breeds, and secondary malignancy were not significant predictors of overall survival time. The degree of contrast enhancement on T1 post-contrast MR images was not statistically significant in survival. Radiation-induced toxicities were grouped according to acute, early delayed, or late. Possible grade 1 acute toxicities was reported in 1 dog, and possible grade 1 early delayed toxicity was reported in 1 dog. Death within the first 6 months of stereotactic radiation therapy could reflect either an acute or early delayed toxicity. 6 dogs died within 6 months of stereotactic radiation therapy. Late toxicities were suspected or reported in 3 dogs that lived past 180 days and may be indicative of grade 2 late toxicity. 2 patients had necropsies performed. 1 patient was diagnosed with necrotic glial cell tumor with a suspected diagnosis of astrocytoma. The second patient died secondary to cardiomyopathy, and the pathologist confirmed the region of the brain where the glioma was reported on imaging was consistent with necrosis secondary to radiation therapy. To summarize the discussion, dogs with confirmed or presumed gliomas who underwent stereotactic radiation treatment had a similar overall survival time of 12 months, matching previous reports. Few dogs experienced radiation-induced toxicities, and those who did had a low-grade toxicity that were responsive to prednisone. Previous reports have also shown low rates of acute side effects associated with stereotactic radiation treatment, ranging from 2 to 14%. Late radiation-induced toxicities were difficult to differentiate from tumor progression, but the low rate of side effects was attributed to dose sparing to surrounding organs. Overall, 90% of the dogs received concurrent steroid administration during radiation therapy to reduce radiation-associated brain edema. While there are ongoing investigations into the efficacy and clinical utility of prophylactic steroid administration, it is recognized that steroids play a role in reducing tumor-associated edema in the brain and clinical signs associated with radiation-induced necrosis. In this study, it was not possible to draw clinical conclusions regarding the role of concurrent steroid use and therapeutic outcomes in this retrospective study. A limitation of this study was the lack of histologic diagnosis for most patients, meaning that subtype and grade of the glioma were unknown. However, some MRI characteristics can be predictive of grade, with poor contrast enhancement being more common in low-grade tumors. A considerable proportion of dogs in the study had synchronous unrelated malignancies diagnosed at the time of stereotactic radiation, with a high proportion being chemodectomas. The presence of additional non-glioma malignancies at the time of diagnosis did not significantly impact outcomes. It is recommended that all dogs with gliomas undergo full diagnostic staging prior to treatment. The use of radiation therapy to treat glioma may provide an acceptable duration of local tumor control to support monitoring or pursuing treatment of additional malignancies in dogs. While the use of stereotactic radiation therapy for canine gliomas is increasing, reports on the use of conventionally fractionated radiotherapy are also encouraging. A recent study showed that canine glioma patients treated with conventional fractionated radiation had a median disease-specific survival time of 698 days, with no significant adverse effects from treatment. It is challenging to evaluate which protocol would provide more durable tumor control for canine glioma, and further studies investigating radiation protocols in canine patients is warranted. Radiation therapy is a viable treatment option for canine glioma, with emerging evidence for more promising durability of tumor control. Canine glioma patients may be utilized as a translational model for human glioma treatment, including investigations into novel approaches for radiotherapy and adjunctive treatments. The use of immunotherapy to improve overall survival outcomes in glioma patients has shown some promise in preclinical models, and further studies investigating radiation protocols in canine patients with the use of adjunctive therapies are warranted. So just to give some personal thoughts, overall I thought the study was fairly well done. As they mentioned, the biggest limitation is there's not diagnosis for a lot of these tumors, or really for most of them. So it's hard to know for certain if these patients all had gliomas. I know MRI can do a fairly good job at differentiating glioma from other possible tumors, but there are times where it could be wrong. And so although most of these patients likely had gliomas, we can't say for certain that all of them had gliomas. And I've had some patients before that lived for over a year for suspected glioma based on MRI with just prednisolone therapy. And of course the question in that patient is it actually a glioma? But for these patients where we suspect that a glioma is present, especially if they are a typical breed where we see gliomas, I do agree that stereotactic radiation therapy is a viable option and is much less invasive. It also has less morbidity and likely mortality compared to doing intraaxial surgery for a lot of these patients. Thank you for listening, and if you have any thoughts, please put them in the comments below. And if you would like me to review one of your articles, or if you would like to have an interview with me to go through some of the questions I might have on an article, please put them in the comments below. Thank you.